Last week I went through how to diagnose someone with fibromyalgia syndrome using the Royal College of Physicians UK clinical guidelines. Today I'm going to let you know how I diagnosed and helped one of my patients in line with these guidelines so you know what to do when you meet someone with fibromyalgia. Hey friends, welcome back to the channel. If you're new here, my name is Mahin and I'm an advanced practice physiotherapist specialising in pain management based in the UK. On this channel we explore ways to improve our interactions with those living with pain to help them create healthier and happier lives. If you're unsure exactly what fibromyalgia is or how to diagnose a patient with this, then I suggest watching my part 1 and 2 videos for my previous 2 weeks after this one. Today I'm going to take you through a case study of how I helped someone with fibromyalgia syndrome. So let's get into it. 42-year-old Mira presented with widespread pain, constant fatigue, unrefreshed sleep, and difficulties concentrating that had been worsening over the past 2 years. She first experienced lower back pain following a breakup from a difficult relationship, and shortly after this she also developed an infection which meant that she had to take a month off work as a journalist. Over the next 6 months she noticed that she started to develop a generalised aching in both her arms and her legs alongside worsening and quite significant fatigue. This is when her GP then referred her to a neurologist to check on these symptoms. But all of her neurology investigations returned normal and not showing an explanation for her symptoms. So Mira returned to her GP, who requested some blood tests to screen for any inflammatory cause to her widespread pain, but again these blood tests came back not showing an explanation for her symptoms. This is when Mira's GP referred her to our pain service and she attended to see me. By this time Mira was now experiencing pain in her shoulders, her knees, her hips, her wrists and her hands, and she described the experience that she'd had as a really kind of distressing, upsetting and confusing one because all of her tests were coming back normal and not showing an explanation for her symptoms, and this just led to more confusion and also led to her questioning whether all of these symptoms are in her head or not, which is not a helpful place to be when obviously the pain is very, very real. She also had to give up work 9 months ago, and she informed me how her function had deteriorated to a point now where she was struggling to even open jars with her hands. This disability and the financial stress following her job loss had led to a real lowering in mood, and she was now on an antidepressant for this. During our first appointment, Mira and I went through her history and all of the previous treatments that she had tried, which included medication, acupuncture and physiotherapy exercises. She informed me that nothing had worked for her pain and the exercises had actually flared up her pain and made it worse. We also covered her medical history, which included IBS, migraines and anxiety with depression. She was on 1 antidepressant and she was on a weak opioid as well for her pain. I did the needful in screening for any serious or systemic pathologies, including any rheumatological or neurological conditions, and made sure there were no red flags, which thankfully there weren't. But I had a strong suspicion that Mira had fibromyalgia from her history, the multiple symptoms that had presented over time, the previous investigations that had not shown any other explanation for her symptoms, and also the poor response from conventional treatments that she had tried. So I then moved on to the American College of Rheumatology's fibromyalgia diagnostic criteria to aid my diagnosis. I always prefer to go through this diagnostic criteria with my patients because it can be helpful for them to piece together all the different symptoms they may have been experiencing, and almost even just going through the criteria itself provides a lot of answers. But also going through the criteria can help prompt patients to think of any symptoms they might have missed out from the history or any relevant bits from the history that they thought wasn't relevant or fitting in with their presentation, but may actually be very relevant for the fibromyalgia diagnosis. For more on using this diagnostic criteria to reach a diagnosis of fibromyalgia, check out my previous video on how to diagnose fibromyalgia that I'll leave a link to in the description below. In Mira's case, she had a widespread pain index of 11 and a symptom severity score of 10. Because her symptoms had been going on for longer than 3 months and there was no other explanation for these symptoms, she met the ACR criteria for the fibromyalgia diagnosis. And this is quite a typical presentation of fibromyalgia, with some common things to look out for if you do suspect that anyone may have fibromyalgia themselves. However, we can't just leave it at the diagnosis, and the next part that I'm now going to talk about is almost as important as the diagnosis itself. The first part, as with any consultation, is to listen to our patients to understand their pain and their journey. And a lot of this would have already been done in the lead up to the diagnosis of fibromyalgia. And it's really important to do that listening first, because here is where we can now use their anecdotal evidence from what they told us earlier to explain what fibromyalgia is and the options that may be helpful moving forwards for them. But similar to when we reach any diagnosis, the most important thing first of all is to explain what the diagnosis is. So I'll tell you how I explain fibromyalgia to my patients. How I do it is I first of all start by explaining pain. So I explain pain, and I usually explain that there's more than one type of protective system. So our pain system is a protective system, just as our fatigue system is, our stress system is, and our immune system is. Now, pain responds to anything the body sees as threatening. I use the word body here rather than brain because I feel like it's an easier in rather than mentioning brain straight away. A lot of patients report that they've been made to feel like the pain is all in their head, or they've outright been told that the pain is all in their head. So I want to soften the introduction with this by using the word body rather than brain. Okay, we come onto the brain stuff a lot later when the patients are a little bit more open to this idea and a little bit more accepting of the diagnosis. So I explained that our body responds to anything it sees as threatening as pain, because pain is our protective system. Now, this can be physical or structural things, like if a patient twists their ankle, pain's there to stop them from walking on that ankle to protect it. But pain also responds to other things the body sees as threatening, and that can be things like stress, poor sleep, lifestyle changes, any previous trauma that they've had. And by mentioning these other things, hopefully sometimes it makes patients think back to their history and the timeline of their symptoms to see if any of these other factors may be contributing towards their pain picture. Again, a very soft touch way of mentioning stress, sleep, or even trauma that may have an influence on pain. So here we're trying to make patients realize that actually pain is much more than the structural stuff going on. And I usually do say to patients that, 20 years ago, we used to think that pain was only there because of damage, but our understanding of pain has come so far since then. And we now know that actually for chronic pain, there are so many other factors that are involved with pain beyond structure and damage alone, and often there is no presence of damage when we are experiencing chronic pain. And that is especially the case with fibromyalgia as well. So fibromyalgia isn't always associated with damage. We don't have to have a physical trauma for the onset of fibromyalgia. Sometimes it can be linked with physical trauma, but usually the trauma might be more psychological or emotional trauma that they've experienced recently or even earlier on in their lives. So once I've mentioned that pain is our protective system, I let them know that in chronic pain being pain that lasts for longer than a 3-month period. In chronic pain, usually this pain system has become overprotective. It's almost become too efficient at doing its job. In my previous video, I talked about a burglar alarm and how the burglar alarm can be related to our pain system, and how sometimes our alarms, the burglar alarm becomes overprotective, over-efficient, and oversensitive, and the same thing happens with our pain system. And this can also happen in fibromyalgia. So in fibromyalgia, it's when that pain system, that protective system, has become overprotective, okay? And that's why things that didn't used to be painful become more painful to do, like walking, or in Mira's case, undoing jars, things like that. And it's also when our pain system becomes overprotective, that's also when we can start to feel pain in different areas of the body as well, like we do in fibromyalgia. And it can almost feel like the pain's traveling to different parts. Now, this is not because there is a specific structural issue in a particular joint or muscle. It's because this whole pain system in general has become overprotective. Okay, so rather than a localized issue, it's now a generalized nervous system issue. And often pain shows up with other symptoms as well. So the fatigue element of things, sometimes people have lower immune systems as well with fibromyalgia. And that's because those two are also our protective systems along with the stress system, as I mentioned before. Going through this explanation can be really helpful and is absolutely needed because it can start to help patients make sense of what's going on for them. And it's really important to mention that fibromyalgia is a long-term condition and that it's not always possible to get rid of pain completely, okay? There is a possibility that the pain may be along for the journey, okay? So they may be in pain for the rest of their lives, but it's really important to mention this. Previously, when I've done this with patients, although it's uncomfortable initially to hear that, and can be really distressing and worrying to hear that, my patients have actually come back to me and they've reported that this was actually a really positive moment in their journey in moving forwards in the presence of their pain. And it can be a really powerful moment even in clinic when you do say to them, there is a possibility your pain may not go. And it's probably the moment that patients break down and they get more emotional, the tears start to flow in that moment. But it is a really important moment in helping people move forwards then, because if the pain is there for the journey, we must then find a way to live well with pain. And that's where we come in as physios, as nurses, as doctors, as OTs, as psychologists, or are there any other health professional that's working with pain. That is our role. It's to help people live well in the presence of their pain. So then after I've explained this, and to help patients consolidate what I've just told them and, you know, improve their understanding of fibromyalgia and make sense of the symptoms they're experiencing, I always signpost them to a few online resources. So I usually signpost them to a webpage on fibromyalgia, some short videos that explain pain and why pain persists, and also I signpost them to this YouTube channel. I always check the resources that I'm signposting them to quite regularly to make sure that there's no misleading information on there, because the internet can be a great place, but it can also be a very confusing place. So I always make sure that the resources that I'm using are up to date, evidence-based, and giving the right information. Education is always the next step following a diagnosis, and it's so important that we do this well. Sometimes we try and jump ahead straight to management, straight to treatments, without doing this education bit first. And this is arguably the most important part. Without education, we can't move towards acceptance and living well with pain. Education must come first, only then can we move towards acceptance and a willingness to live in the presence of this pain. So after reaching the diagnosis of fibromyalgia and going through and educating the patient on what this condition is, the next thing to do is identifying or helping the patient identify what their values and their goals are. For more on how I help my patient set values-based goals, check out the link in the description to the video that I did last time. I won't cover this today because I've already done a previous video on this. But after we've identified the values and goals, I then inform the patient of the options available to them within our service and help them reach a shared decision on what the option may be best for them, or options may be best for them that fits in lines with their goals and their needs the best. So just to give you an idea of what we offer in our pain service, so we offer one-to-one specialist pain physiotherapy appointments that I do. We have one-to-one psychology appointments. We have one-to-one appointments with rehab therapists who help with functional exercises and including general activity into daily lives. We also have medication optimization clinics, which I also do. And we have group options as well. So we have a pain management program. We have a face-to-face version of the pain management program, which is an 8-week-long program. And we have an online virtual option as well for those who can't attend face-to-face or for those who don't need as much depth as the face-to-face program. We also then offer gym groups for our patients as well, so that they can actually explore movement and exercise in a supported environment with some other individuals who may be having similar physical challenges as themselves. So we have a range of options available within our service, and usually it's a combination of a few of these that best suits the patient that we agree. One thing I really want to be clear about from this video is it's important to note that we don't have to do everything that I've talked about in this video in the first appointment when we meet a patient. I think that can sometimes we're setting ourselves up for failure if we try to do that. We end up doing loads of things, but nothing well when we're trying to fit everything into one appointment. So sometimes, you know, doing the initial bit first in terms of taking the history, potentially discovering a diagnosis or reaching a diagnosis and coming back and then actually setting these goals and discussing the options in a second appointment is reasonable, I think. Often if I suspect a diagnosis with fibromyalgia, what I'll do is I'll explain what fibromyalgia is to the patient and I'll send them away with some resources to look through before our next appointment, when hopefully we agree on the diagnosis of fibromyalgia and then we discuss a plan with the options moving forwards. And this is what I did with Mira. We didn't formally reach a diagnosis of fibromyalgia, although I had a very strong suspicion of this and she did meet the diagnostic criteria that we did within the appointment. But what I did was I sent her away with the information, as I mentioned. And I think for me, this is personal preference, but I like to reach the diagnosis of fibromyalgia with my patients. I like it to be a joint decision almost, because I just find that this is more helpful in helping them reach acceptance and a willingness to live in the presence of their pain a lot quicker. Sometimes there's a big delay between diagnosis and that acceptance, and I think something that can speed it up is also putting the patient in control, and coming to an agreement together that actually these symptoms potentially fit with this diagnosis, or what their experiences are fit. And I have never had a patient that I've sent away with information about fibromyalgia come back and say this is not what they feel it is. Every single time, and I'm trying to really think off the top of my head for, a case that didn't fit in line with this, but every single case that I can think of off the top of my head, and this is I don't know how many tens or hundreds this is now, each time patients have come back and said, you know what, it felt like I was reading a script of my own life, okay, or I found that all of these symptoms really fit with my experiences. And then we reach the diagnosis together, okay, and move forward with that. And the GP or the physician gets a letter saying, okay, this is the diagnosis now. And that's really empowering for patients as well. And it can be a really good moment because they've had all of these answers that now have a label or a diagnosis attached to it. It doesn't provide all the answers because we still don't know a lot about fibromyalgia, but there's a diagnosis now, and that's really important for patients. So for Mira, it was actually our second appointment when we formally reached this diagnosis of fibromyalgia, and we put it on her documentation. I sent a letter to her GP. It's also when we identified her values and goals, and it's when I discussed the options available to her, and we made a decision based on these options, what was the next step moving forwards. And in Mira's case, the options that we both decided were best for her was referral onto our face-to-face pain management program, an appointment with our rehab therapist for some one-to-one sessions, and also another review appointment with me to discuss optimizing her medications. For more on how to explain fibromyalgia to your patients and how to diagnose fibromyalgia more confidently, check out this custom playlist that has my most popular videos on this topic. Thanks for watching, take care, and I'll see you next week.